we can take melanocytes from unaffected skin and essentially transfer them to the vitiliginous skin. And what that's doing is it's creating a blank slate. The surgery in and of itself, by bringing those melanocytes to that area, can repopulate and create repigmentation.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
What's up, Hadar? I've just been thinking, we've been doing a lot of stuff around inflammation. What about pigment?
What about when pigment meets inflammation? Or lack thereof.
Oh man, now you're getting deep.
Yeah, I know. I want to talk about vitiligo today because it's a condition that we see all the time, and dermatologists have known this for a millennia. However, we have some new discoveries, some new treatments that really follow a lot of mechanism of actions that have been elaborated. And a lot of this is kind of veering into the area of more holistic care. So this is really, really bread and butter for us, don't you think?
Oh my gosh, I think vitiligo, especially now that we're seeing that the demographics are changing and vitiligo becomes even more conspicuous on people, I think this has become a big thing and it's more prevalent. But you know what? We've got an expert on hand. You and I don't have to sit here bantering about it. We've got someone we can pepper questions to. So we have Dr. Ammar Ahmed, and he is coming to us from the Division of Dermatology at the Dell Medical School at the University of Texas in Austin, and they're part of the Department of Internal Medicine. And Ammar, thank you for joining us. I know that you do a lot of research in vitiligo. You also do medical education. You're the program director. It sounds like you've got enough stuff to do, but we've roped you in to talk about vitiligo today.
Well, I'm happy to be here, guys. Happy to be here.
Well, why don't we start first with a little bit of background? Can you tell us what is new in vitiligo? Conceptually, have we learned anything new about the mechanism that leads to the disease, or maybe more with kind of an eye looking at the therapeutics?
Yeah. So let's talk about maybe pathogenesis first. Over the last several years, there's been a lot of work that's been done by several people who study vitiligo, including John Harris at University of Massachusetts. He's done quite a bit of this work, but others as well, looking at the different mechanisms at play. And one of those things that has come out of that is the certain pathways, immune pathways, specifically the JAK-STAT pathway, which is associated with the interferon gamma pathway. You also have the IL-15 pathway. And so those are some of the immune pathways that companies that are creating pharmaceuticals or trying to look at pre-existing pharmaceuticals for vitiligo are focusing on. And the evolution of that has been some exciting developments that have already occurred and that are in the pipeline for vitiligo. And probably the biggest one is topical ruxolitinib. So topical ruxolitinib was FDA approved for vitiligo by last year, I believe. I think it's about a year and a half, something like that. And that's the first FDA-approved medication to repigment the skin in vitiligo. So it's very exciting. And there's other things that hopefully will be coming soon or soon-ish. With all these, there's sometimes it's not next year, but maybe 3 years or 5 years or 7 years down the line. But hopefully we'll have some maybe systemic agents as well too. But ruxolitinib for now is exciting for all of us, and we've been trying to incorporate that as one of the new treatments as we take care of patients.
Ammar, anytime it comes to FDA approvals, I always think of geologic time. So
Exactly.
like a pseudo geologic time. But speaking of geologic time, not that we're all dating ourselves, but Mark, can you tell us a little bit about what got you interested in vitiligo? What is it that drew you into this disease? Because there's so many to choose from in dermatology.
Yeah, it's a couple things. So number one is that the treatments are not very good for vitiligo, or at least traditionally they have not been very good, right? So it's ripe for the picking. This is a disease for which we need help. We need new therapeutics. We need additional basic science and translational science to inform how do we best take care of that patient? So the gaps in the need, that was part of it. Another thing was I'm of South Asian descent, right? And if you look around the world, there is so much stigma and there is so much social baggage and comorbid mental health issues that can encompass vitiligo in all around the world, but that seems to be magnified in South Asia, for example, and in many other countries around the world as well too. So, personally, from the communities and the families that I'm from, having vitiligo is a big deal, and it can really affect people's lives just as much, if not more, than some of our more symptomatic dermatologic diseases. And so, those were a couple of things that attracted me to vitiligo. And I think that when you have patients who get better, who repigment, they are thrilled. They're absolutely thrilled, even though it's generally not itchy or symptomatic or anything like that. It's really, gosh, the joy and the improvement in quality of life that it brings them is incredible. So those are some of the things that brought me to it. I had a wonderful mentor, Dr. Amit Pandya, when I was a resident at UT Southwestern, and he is an expert in vitiligo too. So I had fun taking care of patients with him. That's where I learned some grafting and surgical procedures with vitiligo. And the rest is history. And I've kind of set up a practice in which I like to take care of patients with vitiligo, and we're doing a lot of fun things there. And that's basically where I came from.
That's very interesting, Ammar. I'm wondering if you can share with us some of the stories that patients tell you, maybe a story or two that kind of stuck with you, to give our listeners a sense of what is this kind of impact can do. Because like everything in skin, I think some people from the outside looking in will say, well, so you have a little color change. It's not going to kill anybody. What's the big deal? Can you give us a
Sure.
story or two?
Yeah, sure. So, I think one of the big stigmas is that it's infectious, it's contagious, right? That's a big thing. And I don't know if that historically, comes from some, confusion with leprosy or things like that, but that seems to be a big thing. So I've had patients, specifically patients of South Asian heritage, and they were so worried that when they developed vitiligo, am I going to spread this to other people? Why do I have this? Is it something that I picked up from somewhere, or am I going to pass this along to other family members or what? So even though there's a genetic basis, clearly we know there's no infectious basis. So that's something that hurts people at their core, that they think that not only are they dealing with the disease, but this is a potentially a contagious disease, and they can potentially infect all of their loved ones and the people around them. So that's one thing that comes to mind, that I've had multiple patients actually come with those concerns. And sometimes you tell them it's not, and still, like, they're like, "Are you sure? Are you 100% sure?" It's sometimes it takes a lot of reassuring and convincing that it's nothing that you're going to spread to anybody else.
Right. And I'm sure patients who are, for example, at the age where they're dating, for example, that can be a huge problem, regardless of even the heritage or social background you're coming from. I think it's always something that kind of goes out there. I know some of my patients have shared that the embarrassment, if you have if you have vitiligo on your hands or your
Mhm.
face, these are things that are noticeable on the first date, as they say. And so it's really been a barrier, makes people, really cave in emotionally and really close themselves in their own cocoon. So thank you for helping us to illustrate this. I want to go now to this new mechanism that you threw out there, at least one of them, which is JAK inhibition. Until now, really all we had, well, most of what we had, the most common therapies were steroids,
Mhm.
just pound the steroid jar, hit them with maybe an injection of steroid, whatever you can do to really stop the progress, work at it. And there were some results, but a lot of side effects. Can you explain to us conceptually how this process of JAK inhibition is different than using steroids for the patients from a safety perspective or an efficacy perspective?
Yeah. So, JAK inhibitors are targeted, right? So they're targeted, it's one specific pathway in the immune system pathway that's targeted, as opposed to steroids that are knocking down your immune cells in general. And so when we think about systemic immunosuppression, at least hopefully the level of immunosuppression that you would get being on a JAK inhibitor would hopefully be more targeted and have a better side effect profile than just being on systemic steroids for long terms. Obviously the latter is terrible for your body. And when we look at topicals, there's the same concept, but also what else do topical steroids do, right? They thin your skin, they cause telangiectasias, they cause stretch marks, all of those things as well with chronic use. And JAK inhibition shouldn't cause any of those things. To our knowledge, topical JAK inhibitors appear to be safe. One of the things that I think we're still keeping an eye on is could there be any potential link with skin cancer? Because when you look at systemic JAK inhibitors like systemic ruxolitinib, that's one signal that pops up, a potential risk with squamous cell carcinoma and other skin cancers. So could that occur in topical application of JAK inhibitors like ruxolitinib? It's a theoretical, have not seen that signal come up in any of the studies for vitiligo, for alopecia areata, or any of the diseases that it's used for, eczema so far. So far, so good. And so we think that the topical JAK inhibitors will have a better side effect profile. And I think that the next realm of systemic inhibition will again be more targeted as well. Even amongst JAK inhibitors, there's different receptors. There's JAK1, there's JAK2, JAK3. So I think that's a lot of what's going to come out in the future. What's the sweet spot between what can we inhibit that will make skin disease better, but will also decrease the risk of serious systemic side effects?
Now I want to move a little forward because you mentioned kind of in passing doing surgery for vitiligo. And
Oh
I
yeah,
think
right. How many people do that in the
I
nation?
think so I think some people may have either fell off their chairs, and folks, I hope you're back on your seats right now, or they like checked their headphones, or hopefully you didn't veer off the road when you're listening to this. What do you mean surgery? So I want to
By the
take
way, if you got an abrasion when you fell off your chair, you could probably graft some skin for that too.
exactly. So maybe you can touch a little bit on the concept of surgical interventions for vitiligo as we move towards more holistic care, because that's really what I want to get to, right? Combining all these therapies. So what did you mean when you said surgery for vitiligo?
Yeah. So, there's medical therapies for vitiligo, conventional medical therapies, holistic integrative medical therapies, and then there's surgical therapy. Because there are some patients for whom the former does not work, or they will work to an extent, but at the end of the day, you're limited on how much improvement you can get with phototherapy, with topicals, even with systemic immunosuppressants. And so for those patients, if their vitiligo is stable, meaning that they're not gaining any new lesions, they're not getting any extension of old lesions, and it's been like that for a long time, then potentially we can graft those patients. We can take melanocytes from unaffected skin and essentially transfer them to the vitiliginous skin. And what that's doing is it's creating a blank slate. The surgery in and of itself, by bringing those melanocytes to that area, can repopulate and create repigmentation. But then it also allows us to then treat those new melanocytes with phototherapy, with our topicals, with the treatments that we do with vitiligo, to try to essentially you have a substrate, you have a something to work with once you introduce melanocytes in there. And so that can be really the only effective option for some patients with burnt out vitiligo, inactive vitiligo, but vitiligo that's also recalcitrant to therapy. And sometimes we see that when all the hairs have gone white, right? Like if you have patients who have a patch of vitiligo and it's completely poliotic, there's no pigment left in those hairs, it can be extraordinarily difficult to get the color to come back with medical treatments. But surgical treatments allow a canvas for which we can repigment, or at least sometimes we can repigment.
And can you describe what are some of the limitations? Is there a limitation in area, for example, of how much you can treat?
Yeah, absolutely. So really small areas is really what you need to treat. Now, it's not a one-to-one ratio. When we graft, there's something called an expansion ratio, in which case sometimes we use a 1 to 5 or 1 to 10 or even as big as 1 to 20 expansion ratio, meaning let's say we're doing a 1 to 10 expansion ratio. That means we could potentially repigment and treat an area 10 times the size of the donor site. But even that, even given those expansion ratios, if we're taking a small split thickness skin graft from someone's buttock, right? Oftentimes we take a sample about the size of like a stamp, or maybe a little bit larger than that, right? Still, even if we're treating an area that's 10 times as big, you can't treat half the body or anything like that. So there are definitely area limitations. It can be painful when we numb those areas up and we have to then dermabrade those areas or use lasers or whatnot to dermabrade those areas, the areas that we graft. there's limitations on pain and anesthesia and that type of stuff. So we can't graft a gigantic part of the body, but relatively small areas we can graft. And then the other aspect of it is that there are some limitations into the success of grafting based on other conditions. For example, we know that segmental vitiligo is almost always better for grafting than non-segmental. Now, we graft people non-segmental as well, but segmental is the holy grail when it comes to surgical treatments for vitiligo. Non-segmental, if you have one or two or three focal areas that are stable but have not responded to medical treatments, then yeah, we could certainly consider those. But let's say those areas are on the distal fingertips or on the toes. Unfortunately, those areas that are exceedingly difficult with medical treatments can sometimes be hard with surgical treatments. It's not a never, it's not that they never work, but unfortunately, those areas can be a little bit more challenging as well.
Can you just elaborate briefly, because you introduced a concept here of segmental versus non-segmental? Can you explain what that means and how does that change your thinking about the disease?
Yeah, so there's a debate if they're even exactly the same condition or not. The end phenotype is depigmentation, so they look the same. But segmental vitiligo happens on one side of the body. It happens not the complete side of the body, but one particular segment of the body. Now, does that correlate to some area where the nerves innervate? We don't know, but it's generally one section of the face or one section of the arm and shoulder or one section of the thigh or whatnot. It doesn't have to be just one specific area. It can be broken up into two or three or four or several different geometric areas, but it's limited to one side and it's limited to generally one relatively small area. Now, segmental vitiligo often happens early in life. So kids, adolescents are often the people that get segmental vitiligo. And then oftentimes it can come quite explosively. It spreads for a while. That can be months to years, but usually not many, many years. And then oftentimes it stops. Every now and again, it can reactivate. Every now and again, people with segmental vitiligo can also develop non-segmental vitiligo on top of that. That's called mixed vitiligo, and it happens to about 10% of people with segmental vitiligo. But for the majority of people with segmental vitiligo, that's it. It burns out, and then oftentimes it does not expand after that, which means that oftentimes it's really stable. And so even though medical treatments can sometimes be hard for burnt out segmental vitiligo, surgical treatments can sometimes be quite effective. And again, this is all in juxtaposition to non-segmental vitiligo, which is the more common type, the type that if you Google pictures of vitiligo, you will mainly see non-segmental vitiligo. That's usually symmetric, can happen anywhere on the body. There's certain areas like the hands, the lips, the eyelids that tend to be preferentially affected, but it can essentially happen anywhere on the body. And that's the common type of vitiligo. Tends to respond a little bit better to medical treatments than surgical vitiligo, but segmental vitiligo has the advantage when it comes to surgical treatments.
This is a really nice discussion because I think when we talk about holistic care, I mean, there are some limits on what medical therapy, no matter what we do, have, but it seems like with surgery, you're really able to extend the areas that you can treat at the end of it all. Are there donor sites that are preferable, like when you're thinking about anatomically? And then where's the most often commonly requested site that you end up grafting to?
Yeah, with regard to the former question, so the key of the donor site is that it's in a place that cosmetically the patient won't worry that much about having a scar because you can essentially leave them with a permanent scar. And then B has hair follicles and is not affected with vitiligo, right? So putting that together, usually we use the upper thigh buttock area. That tends to be the most common place. You can certainly take it from any other unaffected skin that has hair follicles. But given the fact that your whole purpose of this is to repigment areas that are more visible, usually people choose areas like that are covered with their undergarments. Sorry, what was the second part of that question?
I was saying, are there sites that you tend to graft into? Is it like most across? Is it the hands where, or the feet where it tends to be really difficult to repigment otherwise?
Yeah, people ask for the hands and feet a lot, but I will say that sometimes it's hard. If it's the area of the hand proximal to the knuckles, then we can do a pretty good job with that. If it's really just the distal fingertips, it can be hard to get significant improvement to that area. So, unfortunately, even though grafting can provide some relief to patients who otherwise don't get better with medical therapy. Still, there's some limitations. And again, the distal fingers and toes can still be hard with that. They're in some, I believe in India and some other countries, they're experimenting with dual cellular grafting combined with a follicular unit grafting, which is essentially like a hair transplant and a vitiligo cellular graft combined together. And that seems to maybe be a little bit more effective for the distal fingertips. But here I'm not aware of anyone doing that in the United States, and so we still don't have a holy grail for fingertip vitiligo, even in terms of surgical treatments. But face, I would say face is a big one, right? So people who have segmental vitiligo or even
Yeah,
non-segmental
that
front
makes
part
sense.
vitiligo, yeah, especially if they have poliosis, and so it's really hard to get better with medical treatments. That's great for grafting. I mean, that's fantastic for grafting. Also, upper chest, neck, those are places that tend to be visible and tend to be places that people would love to get their color back. And those places usually respond really well to grafting.
Great. That's wonderful. We got a nice review on what's new in medical, exposed to the whole idea of surgical. You mentioned briefly the concept of light therapy. I want to ask you, how do you put this all together? Because here we're all about holistic care for our patients. How do you try to combine this for a patient that presents to you using all the weaponry in your toolbox to really achieve maximal effect?
Yeah, yeah. So, I mean, for me, it's really for the average patient with spreading active non-segmental vitiligo, because that's a lot of the patients that will walk into our exam rooms. It's usually a 3 to 4 part treatment regimen, right? So the first part of the treatment regimen is the topicals that we talked about already. Sometimes we still use topical steroids and calcineurin inhibitors, but we get our newer ones like ruxolitinib that can be helpful in that regard. Number two is phototherapy, right? It's narrowband UVB phototherapy that is really the gold standard treatment in 2023 for the majority of patients that you'll come across with vitiligo. And we can administer that in the office. We have lots of mechanisms to administer that in the comfort of people's homes as well, too. Number three is for some patients, their vitiligo is explosive enough, active enough that we need to do other systemic medications by mouth, whether that be a course of systemic steroids, methotrexate, things like that. It's certainly not all patients, it's for a minority of patients. And then fourth is other dietary and nutritional holistic therapies. And when we start people on phototherapy, I give people a sheet, handout each time with lists certain vitamins for them to take, certain antioxidants for them to take. We have some dietary recommendations on there as well too. So I think putting all those 3 to 4 things together, that's really how we put together a comprehensive treatment regimen for most of like the average patient with vitiligo.
Ammar, what are some of the vitamins and dietary recommendations that you give out?
Yeah, so one of the things that we have on our sheet and that we recommend to all people with phototherapy who are doing phototherapy is antioxidant cocktail, which the 3 main components of that are alpha lipoic acid, vitamin C, and vitamin E. And what those 3 have in common is that they're antioxidants. And again, going back to, okay, what causes vitiligo, right? What is the pathogenesis of vitiligo? We know it's an autoimmune condition, but there's probably another component of that, and that has to do with the melanocyte stress. We think that somehow maybe someone is predisposed to having defective or fragile melanocytes, but there's some type of stress on the melanocyte, and that causes some type of damage to the melanocyte, and that then allows that damaged melanocyte to essentially be a more prime target for the autoimmune attack, right? So the theory is that if you can help control that melanocyte stress, that melanocyte damage, then maybe you can blunt or even prevent that autoimmune attack. And so what is the melanocyte stress? Well, a lot of it appears to be oxidant stress, right? So the natural answer to that would be antioxidants. Let's give people antioxidants, right? I will say that we still need a lot of information and research on this. There has not been a clear correlation with a high antioxidant diet in improvement in vitiligo, but that's what I recommend. I recommend a diet that's high in colorful fruits and vegetables. And we recommend people to take vitamin C, vitamin E, alpha lipoic acid. And specifically for that, there was a study done in Italy several years back that looked at that cocktail for people with getting phototherapy for vitiligo. And they had 2 arms. In one arm, they got the antioxidant cocktail. And the other arm, they just did phototherapy without the antioxidant cocktail. And if you look at the the pigmentation rates, it was significant. I believe it was like 47% in the group that did antioxidants plus narrowband versus 18% in the group that did placebo plus phototherapy. And this is a randomized controlled trial. So, it's one piece of data, but that's a significant benefit. So that is something that we routinely recommend. When people who can't do phototherapy say, am I getting any benefit from taking vitamin C, vitamin E, alpha lipoic? I say, I don't know. I say, certainly don't think it'll hurt. And so it's probably not a bad idea to take. But really the data we have comes more from narrowband in conjunction with the antioxidant cocktail.
That's great. And we don't want you to spill all the beans because, folks, this is just the tip of the spear here. Dr. Ahmed is going to be with us at the Integrative Dermatology Symposium, where he's going to talk about integrative approaches to vitiligo. So you heard a little bit of that, but he's going to really focus on the post-steroid era. So if you want to hear him live, ask him all the questions I know are brewing right now in your brain and get all these excellent tips that you just heard. Come to the meeting. He's speaking on the first day, so be there early. Do what I do. Sit in the front row, take out my pen, and start writing notes. Before we let you go, one question to our listeners. Is there a good resource, a good website for patients, practitioners to learn more about vitiligo, a place they can go as this field keeps growing?
Absolutely. Global Vitiligo Foundation. So their website, I believe it's globalvitiligofoundation.org. And when you go on there, the first page you'll go on will say, I am a person affected with vitiligo or a loved one of someone affected with vitiligo, or I am a healthcare provider. So you click on whichever one, and it is a wealth of resources. There's support groups that are integrated into that. There's tons of information on all the newest trials that are coming out and all the medications that are available. So that's what I recommend. The number one website that I recommend to people is the Global Vitiligo Foundation website.
Amazing. Well, Ammar, thank you so much for this wealth of information. I think we got a lot done in a relatively short amount of time, and I look forward to seeing you in Reno, and thank you for your time and your expertise.
Oh, it's my pleasure. I will see you all there.
Guess what, Hadar?
What?
Tickets are selling fast for the 6th Annual Integrative Dermatology Symposium.
Wow, that's amazing. Each year this event gets better and better.
Yes, it does. And as a special gift to our podcast listeners, we're offering 15% off registration using the code PODCAST15.
Wow, that's a great deal. And prices won't be going any lower this year, so best to get on it now.
So true. And if you haven't joined us in person yet, this is the year to come have fun at the Grand Casino Resort in Reno, Nevada.
Yep, you'll get to connect with practitioners, engage with exciting research and content, and learn what the integrative movement is all about. Now, all this while nestled between the Sierra Nevada mountain range and downtown Reno.
All that nestling sounds skin-tastic. I know we're all about having fun at the symposium, but this year is over the top. Now look, I'm not much of a golfer, but they have over 40 courses along with rock climbing, equestrian trails, boat tours to Tahoe, pools, arcades. You get the picture, so much more.
Yes, it's definitely a family-friendly getaway. And while they are at the movies, we'll be feasting on, well, no pun intended, but nutrition.
My appetite is whetted. This year's theme has been long awaited. Nourish the gut, nourish the skin as we delve into nutrition.
We can't wait to see you this October 27th through the 29th in person or virtually.